Welcome everybody to today's lecture. We're going to discuss pediatric abdomen. Now, the point of this lecture isn't to make you ready to go work at any pediatric hospital, but rather get you ready not only for your boards, because there are a handful of pediatric abdomen questions on there, but to also just expose you to some of the more common things that you're going to see in a general hospital. Now, a lot of these are going to be parents bring their kids into the ER, kids in pain, doctor doesn't know what to do, and because of radiation and all of that stuff, they like to lean more towards ultrasound, see if they can see something. And so you might get some of these cases in your room because why not? We have ultrasound, let's take a look, see if we can find it. So that's going to be more of our GI tract stuff. I also want to expose you to the most common malignant tumors, because those are really great board questions. So we want to make sure that we know the names of those and know where they are located. And then finally, just kind of expose you to some of the more common things if you have a newborn floor, if you have neonates on your floor. Again, they don't like to do X-rays, they're not going to do CTs, they're going to take a look with ultrasound just to see what they can see. So we're going to take a look at some more common things that we might see in the neonate. So again, this is a very brief overview of pediatric conditions. There are 600-page textbooks out there just on pediatric ultrasound. And so I just again want to introduce you all to some of the more common ones and just kind of get you ready for your boards more than anything. So let's get started. So the first pathology that we're going to talk about is hepatoblastomas. Hepatoblastomas are malignant tumors that arise in the liver. So these are going to be the third most common malignant tumor of childhood. And these are quite often associated with Beckwith-Wiedemann syndrome. So if a patient has this condition, they are quite often going to be sent to the ultrasound department maybe every 6 months to check for tumors. And so we really want to make sure that we're looking through the liver, looking for any abnormalities within the liver. Hepatoblastomas are usually going to pop up in the right lateral lobe of the liver, so way off on the side in that right lobe. Clinically, these patients are going to present with elevated AFP, and as we've learned in other adult conditions, anytime there's AFP and you're not pregnant or female and pregnant, that's a bad sign. That usually means some sort of cancer is going on. So elevated AFPs, we're going to see these in children 5 years of age and younger. And usually it's painless, but it's a palpable abdominal mass. The child's abdominal girth is going to get larger. If you have children or have ever been to a well child visit with their pediatrician, they're always kind of poking around on the tummy. They're feeling around for anything abnormal like a palpable mass. Sonographically, then we're going to see typically a very large solitary mass within the right lobe of the liver. Sometimes they have calcifications. Sometimes they are heterogeneous just because of different levels of necrosis or just how the tumor is growing. And then if we put color on, we'll see increased vascularity throughout the tumor. And depending on where this tumor is and how it's growing, it may extend into the portal vein, which can cause thrombosis. So we have a couple of examples here of our hepatoblastomas. Here we can see a very large echogenic heterogeneous structure within the right lobe. And again, we can see another example of it here. Probably a little bit of central necrosis here. We're seeing some increased heterogeneity. Here's that right kidney underneath it. So just a large, hunky, gross mass in that right lobe of the liver. So remember that this is hepatoblastomas are liver-based, and they're the third most common. Another relatively common thing that you might see on the liver is a form of infantile hemangioendotheliomas. Now, what will happen is the child will come into the clinic to see their pediatrician, and what they have are a bunch of these skin hemangiomas, and we can see one here in this picture. So these skin hemangiomas are just little red lesions all over the skin. Sometimes they're little dots all over, sometimes they're a little bit bigger like this. Sometimes they're, if you've ever heard of a port wine stain, it takes up a really big area and it's kind of flat. So they have these or hemangiomas on their skin. And when that occurs, it's likely that there will be hemangiomas on the organs within the body. So it's not uncommon for them to then get an ultrasound to follow that up. So working in a pediatric hospital, I've seen this quite often. So that's why I just want to make sure that we put it on there, because it looks kind of scary by ultrasound, but it's actually all benign. So clinically, again, they might, if the hemangiomas have grown large enough, it might be a palpable mass. Otherwise, we'll see those hemangiomas on the skin, and typically, lab-wise, we'll see elevated transaminase, and then we typically see it in girls as well, but I've seen it quite often in boys. So like I said, these look kind of scary. Doesn't that kind of look like mets, like what we saw on adult? So a little scary looking, but it's completely benign. So sonographically, the hemangioendotheliomas are going to vary in size. They can have itty bitty ones, they can get rather big. You might have single or multiple ones. If we put color on them, they do get filled in with color, and they're usually a little bit more echogenic. And we can see that the parenchyma around is also quite echogenic, so these are probably looking a little bit more hypoechoic. They do take on a little bit more of an echogenic appearance. One of my most recent times that I saw this, they had a bunch of them right around the porta hepatis, and so I took cities through there, measured them all, because what they're going to want to do is figure out, they're going to follow these up, especially the first time that you find them. They're going to follow them up, and they want to see if anything is growing. And if anything is growing really drastically, they might want to biopsy it just to make sure it's not a cancer kind of hiding within all these other, hopefully benign structures. So make sure to measure your structures, check with your radiologist, see if they want more structures measured or if they only want the biggest 3. Biliary atresia, we probably touched on briefly during the biliary pathology lecture, but biliary atresia is something that is quite often seen in neonates. That's when it's going to present its strongest. We're going to see that the infant is struggling with just living in general. It's a very life-threatening disease. They're going to struggle with eating. They're going to be very jaundiced. And what we're going to see then on ultrasound is what we call the triangular cord sign. So biliary atresia means that the biliary tree did not develop. Sometimes it includes that the gallbladder didn't develop, but usually it's the common bile duct didn't develop. And this triangular cord sign is seen right where we would expect that common bile duct to be coming out. But what we're actually seeing is just kind of like a bunched up, I don't know, I guess peritoneum, like a bunched up area of what should have been the common bile duct is just now this kind of ball of echogenic material. So it's right at the porta hepatis, kind of makes this triangle, and that's why we call it the triangular cord sign. And then of course there won't be any sort of common bile duct through this area. Choledochal cysts, I know we talked about during our biliary lecture, and so I just want to touch on it again because again this is usually something that we do diagnose in children. Remember that there are 5 types of choledochal cysts, number 1 being the most common, and we typically see that this is going to affect the common bile duct. So the common bile duct dilates, kind of looks like a cystic area, but it's really just a dilation of the bile duct. We quite often see this in Asian children, more likely. And remember, we think that it is due to the backup of pancreatic enzymes backing up into the common bile duct, weakening the wall so then it can expand and kind of look like a cystic dilation. All right, so we're going to switch gears a little bit into some more GI tract stuff. This stuff is probably going to be a little bit newer for you. You probably have heard of all of these, but we're going to discuss a little bit more what our role is as a sonographer in diagnosing these. So the first one we're going to talk about is appendicitis. And my experience with appendicitis, I have done it pretty much everywhere that I have worked. Some doctor is like, can we take a look at this kiddo? I really think they have appendicitis. Can we just take a look? You're going to get that question a lot. And the more you do of these, again, it's 100% a number game. The more you do of these, the more you feel comfortable with them. You know what a positive is. You know what a negative is. You can find the appendix regardless. The first few times that you do an appendix ultrasound, you're going to be like, I have no idea what I'm looking at. And that's okay. You're going to do your best. You're going to take a really good look through there. You're going to find a senior sonographer to help you out. You're going to talk to your radiologist to help you out. Some radiologists actually really like to scan appendix for themselves, just so they can confirm. The problem with appendix ultrasounds is that if we don't see it, it doesn't mean that it's negative. The appendix can hide rather easily, and that's why we really want to make sure that we are taking a very good look through the area, rolling the patient around, changing positions, having them empty their bladder, trying different things so we make sure that we really evaluate the area in its entirety. So the appendix is this tubular structure that comes off the cecum. So we have our small intestine. The small intestine joins up with the cecum. So we call this the ileocecal valve. Sits right in here. So that's the ileum joining up with the cecum. And the ileum is the last part of the small intestine. The cecum is the first part of the large intestine. So those join together down in the right lower quadrant. And right off that corner there is the appendix. And so the appendix is like this little worm-shaped thing. And the full name of the appendix is actually the vermiform appendix. Vermiform kind of refers to worm shape. Anyway, it's located right at that corner there. We call the appendix a blind ending structure. And so what that means is we should be able to see the origin of the appendix into the cecum. We should be able to follow that out, and it should end. We should see a clear ending to the structure. And I think that is the biggest part of making sure that we are proving that we have found the appendix. What you're going to see is that it quite often looks like the small intestine that's around it. And if we follow that small intestine, it just keeps going and going and going and going. There's no true end to it. And it's easy to kind of make up a blind end as well. So we got to be really cautious, really judicious, in that we are taking the time to find the appendix and then prove that it ends. The other big thing with the appendix is that it doesn't peristalse like normal bowel does. So we might see something that looks like the appendix, and we're going to sit and watch it. And if it starts to peristalse, then it's probably small bowel, and we got to find something else that looks like an appendix. Usually within the appendix, we'll see a little bit of air and a little bit of fecal matter within it as well. Now, clinically, when these patients come in to the ER or into their doctor, they're going to have right lower quadrant pain. And we say that it's at McBurney's point. So if you take the belly button and draw a straight line out to the right hip, McBurney's point is about halfway through. And what they're going to do in the clinic or in the ER is they're going to push down at McBurney's point, and when they release, that should cause the patient pain. So you might see a positive McBurney's point sign. That's what they're referring to. So there's usually some right lower quadrant pain. Because of that, then the patient usually feels nauseous and might actually vomit. The appendicitis usually causes an increase in white blood cell count because it's kind of an infection that's going on. And because of that, then the patient might also have a fever. Now, what I find with children that I have scanned for appendicitis, the ones that have positive appendicitis, they point right to this McBurney's point. I ask them, one finger, point where it hurts the most. More often than not, it goes right to McBurney's point. And when they do that, I'm really keen in. I'm like, oh, I think this is going to be positive. The other half of the time that these kiddos come in, you're gonna ask them, point to the spot that hurts, and they're gonna go, oh, it hurts like all over here, and they're gonna point in a big circle all around their tummy. And so then I ask them again, you can only point to one spot. Where does it hurt the most? More often than not, they point to their belly button. Those kiddos are usually negative. And something else is going on. It's usually some sort of gastroenteritis or maybe some lymphadenitis. So the kiddos that they're in pain, they do not feel good, they point to one spot, they point right to McBurney's, almost always positive. The other thing too is to kind of watch how your patient is acting. And the more that you scan children, the more that you'll see this, they really feed off of what their parents are doing. So their parents will be like, honey, does it hurt? Oh, honey, I'm so sorry. And like they're kind of doting over their children. Totally get it. I'm the same way with my kiddos. The kid kind of feeds off that, like, oh yeah, it hurts all over. And they feel like now that you're doing the ultrasound, it's hurting even more because the parents keep asking them and kind of revving them up. So really try to get your child to focus on you, focus on what you're asking, get them to point to that one spot. The kids come back laughing, they probably don't have appendicitis. Kids come back jumping around, moving around, they probably don't have appendicitis. The kids who have been positive for appendicitis are in so much pain and are so weak and so lethargic, they just lay there, barely point to the area that hurts, and it is usually positive. So you'll get a feel for just kind of how the kiddos act. Is it something else or is it appendicitis? So when we go in to scan the appendix, we are going to be looking for a non-compressible structure, and it'll measure more than 6 millimeters in diameter. So this is for positive appendicitis. It should be non-compressible, and it's going to measure greater than 6 millimeters. A normal appendix compresses and measures less than 6 millimeters. We're also going to put color on our appendix, and we're going to see that the walls are hyperemic. So we're going to see increased vascularity in the walls of the appendix and in the area surrounding it. We're going to see then also increased echogenicity in the surrounding fat. So we call that fat stranding. It's when the fat also kind of gets inflamed. We're also possibly going to see what we call appendiculus or fecalus, and those are basically just really, really hard fecal matter that is causing shadowing within the appendix. It's kind of like a gallstone, but in the appendix and made of poop. And then lastly, what we're going to be also looking for is a perforation. So the appendix can get to the point where it gets so inflamed, so enlarged that it ruptures. And what typically happens when it ruptures, these kiddos are going to be in so much pain, and then all of a sudden they're going to have some super sharp pain and then feel better. And that's because that appendix grew so large, causing all that pain, it ruptures, empties its contents into the abdomen, and it feels better. It feels really good. But the problem is now they've got all this fecal matter out into the abdomen in the free area. So what ends up happening, we see free fluid, and we see abscesses start to form, and those can be much more concerning and life-threatening. I want to point out this picture here. Again, we have the ileum joining in to the cecum, so last part of the small intestines coming into the cecum, and this is where the appendix hangs out. The appendix can go in any direction that it wants. Most of them are retrocecal, which makes them a little bit trickier to see. And then the other good portion of them are going to be a pelvic, where they kind of dive down into the pelvis. Then you got some other variations where they can be as well, but we really need to take a look all the way up to the liver, all the way down through the bladder, looking in that right lower quadrant, because that appendix can be anywhere in there. So some other tools, again, that you can use as you are evaluating the appendix. Again, ask the patient where it hurts and start scanning in that area first. You're also going to use a tool or a method called a graded compression. And what graded compression is you start off putting pressure on the abdomen with the transducer, and you're slowly going to increase that pressure. And you're going to kind of almost massage or move the bowel out of the way. And the more pressure you're going to put on, the child is probably going to be in pain, but you have to use some pressure to get to the appendix, especially if it's a retrocecal or if it's hiding behind some other bowel gas. You have to use some pressure. And be quick about it, be purposeful about it. Don't just push to push. Make sure that you are using that graded compression, that slow increase in compression to get that bowel kind of pushed down and out of the way. Again, we're going to be looking for a positive McBurney sign, so we can do the same thing. We push in the area of McBurney sign. When we release, that's when the pain is usually felt by the patient. We also want to make sure that we're taking cine clips through the area, both in longitudinal and trans, showing that it's a blind end structure, showing that we can connect it back to the cecum. And then, of course, we want to evaluate for any other structures in the area, looking for fecalus or appendiculus. We want to look for free fluid, and then we want to look for lymphadenopathy or abscesses as well. Free fluid in the abdomen is a little bit more concerning that the appendix is ruptured, but it can also just come up with inflammation of the GI tract. Lymphadenopathy is not uncommon to see lymph nodes that are enlarged with appendicitis, but you can also just have enlarged lymph nodes. And we see that with lymphadenitis in the abdomen, which can really mimic some of the symptoms of appendicitis. And then, of course, we are concerned about abscesses as well. The tip of the kidney, the tip of the appendix is where those abscesses usually form and where that free fluid also shows up. So if you see an abscess or see free fluid in the abdomen, that's most likely going to be hanging out right near the tip of the appendix. So that's a really good place to start too if you're struggling to find it. Once you do identify where the appendix is, you want to make sure that you are, again, getting really good images, showing the radiologist what you are seeing. They may want to come in and scan as well, so don't let your patient go, especially if you think you have a positive one. But make sure you are first starting in transverse. You want to take multiple pictures in the transverse view. It's going to look more like a target sign. And you'll take your compression pictures in transverse as well. And then we're going to measure both the AP diameter and the measurement of the wall of the appendix. So just want to show you here. So usually in transverse, we have the appendix and it kind of looks like this, and we have something like that. And so our AP measurement, we're going to go like this. That should be in normal. It's less than 6 millimeters. If it's positive for appendicitis, we're talking more than 6 to 7 millimeters. And that's just going to depend on your radiologist, what measurement that they like. But 6 millimeters is the one that I want you to remember for your boards and for your test. And then the other thing that you'll want to measure is your wall. The wall thickness increases and also increases the likelihood of appendicitis. So we want to make sure that we are measuring that well. Also in AP, usually doesn't measure more than 1.5 millimeters in a normal appendix. We're also going to then make sure that we put color on the picture. I usually like to do it in transverse so we can really see color kind of lighting up all the walls of the appendix. And then we're going to switch to longitudinal. And we want to show the appendix in its long form, show as much of it, take pieces of it if you have to, but we really want to show what it looks like throughout, because sometimes you have focalized appendicitis where only part of the appendix is inflamed to the point of appendicitis. When that happens, it usually happens at the tip, so we really want to make sure that we find the tip, but it can be anywhere along the appendix. And then we want to make sure that we're looking through the lower quadrants, looking for any free fluid. So here are some pictures of an appendix. We've got the appendix in long here. We actually have some fecalus in there as well, so this is kind of fecal matter. This is probably a little bit more of a fecalith with the shadowing that's coming behind it. So just like gallstones, the fecaliths also shadow. So we have the appendix here. You can kind of see those layers of the wall. Those are the normal layers of the gastrointestinal tract. Again, they're going to get a little bit thicker if the patient has appendicitis. So this is the long view of it. We're showing that tip there. Again, we can see it here in long. And then we switch to transverse and we get a little bit more of a target view. When the internal contents are brighter, that usually represents appendicitis as well. And pay attention to what it looks like around the outside of it. See all this really bright white kind of fuzzy? That's that fat stranding or increased fat aggregationicity around the appendix here. This picture is labeled non-compressible, so you're going to center your appendix, push down on it, and it should not compress. And that's a good time then to assess the McBurney's point as well. See if they have that rebound pain. A couple more things that we might see. Here's a periappendical appendical abscess. And so this is probably part of the appendix right here, but we're seeing this odd fluid collection here. So this is most likely a ruptured appendix. We're seeing a fluid collection. This is going to be full of junk, full of debris, really thick walls to the abscess, and then we're going to see that peripheral vascularity like we're seeing right here. We also then will most likely see free fluid. So these are bowel loops right here, and then we have free fluid kind of surrounding it all. So we want to make sure that we look for any fluid in the abdomen as well. So appendicitis, remember all of the tips that we went through. You're going to use a linear, usually a 9-3 or a 12-5 probe, linear probes. We're a little restricted by the size of the patient. Adults, it's a little tricky to find unless you're really, really good at it, or they're really thin, or their bowel is just cooperating really well. So if you get a chance in lab to take a look at somebody, just take a look through the area, see what you can see. But usually we won't be able to see it because we need to use that 12-5 or 9-3 to really get a good view on the bowel. So older children into their teenage years or obese children might make this a little bit trickier to see, and that's okay. We're still going to take a look. They can always have a CT. Remember that. They can always have a CT. We're just trying to avoid getting them that extra radiation. And then again, just start right where the patient points. Usually where I like to start is down by the iliac vessels. So typically I will get the internal IVC, not the IVC, the internal iliac artery and vein, and then that appendix oftentimes just kind of drapes over the top of them. And so that's really where I start looking, especially if the patient is one of those that just kind of starts pointing to their belly button. All right, so appendicitis, your first one that you find, it's actually kind of exciting. You feel bad for the kiddo, but it's kind of fun because like you spend all this time looking for the appendix. You have so many kiddos that actually don't have appendicitis, and so you start thinking, I'm never going to see one. And then you see one and it looks beautiful. It looks just like these. This will pop out at you and you'll be like, yep, found it, awesome. And then the more you do of them, the more you're going to feel better about it. Here is a quick little video. We're going to watch the appendicitis. There's an abscess at the end of it. So this is the appendix right here. You can see that kind of target form. We've got that echogenic fat stranding going around it. They could probably lose some depth here just so we can see a little bit better, but you'll see this nicely here. There goes the appendix. They're in transverse right now. And then they kind of start to follow it down into this abscess. So this is just really junky looking area here. And that should be right at the tip. It's most likely a ruptured appendix. All right, we're going to move on to another gastrointestinal tract thing that we can look at with ultrasound, and that's called the Hypertrophic Pyloric Stenosis, or HPS. So the pylorus is a muscle that sits at the end of the stomach. So here's the esophagus. Patient eats or drinks, comes into the stomach, gets processed, and then the pylorus sits right at the end of it. And the pylorus is going to be responsible for allowing food to enter into the duodenum. So it's this muscular channel that closes and opens, allowing food to empty out of the stomach. Note that the stomach does have a few parts. It has the fundus, which is up by the esophagus, and then the antrum is that part that leads into the pylorus. So with hypertrophic pyloric stenosis, what happens is that the pylorus starts to thicken. And as it thickens, it no longer can open to let food out. So food gets stuck in here. And typically what happens then is you have young infants. We're talking like 3 weeks old, 4 weeks old. We're not saying a year old, 2 years old. We're saying like 3 weeks old. They eat, they breastfeed, they get their bottle, and then shortly thereafter they are vomiting. And it's not just a little spit up. No, it's vomit. And that's because all of this food has come in. The stomach wants it out. The stomach wants it to go into the intestines, but the pylorus is super thick, and so instead it all just kind of backs up, and then all of a sudden pressure builds up and it's all over the place. Like we talk about like vomiting across the room with pyloric stenosis. So that's one of the questions I always ask parents is like, oh, is it kind of like a spit up or is it like actual vomiting? And if they say, no, a baby's vomiting, then I start to think, okay, this might actually be positive for a pyloric stenosis. So a couple other things we notice with patients with the positive pyloric stenosis is that they tend to be white males and, oddly enough, usually firstborn. Okay, so if you have a firstborn white male, that puts them at a higher risk for developing pyloric stenosis. As I mentioned, typically we do have vomiting. We call it non-bilious vomiting, and that's because there isn't any bile kind of backing up through all of this. So it's usually milk goes in, milk comes out. There's no other digestive juices really going on with it. The other thing that we'll see, and this is why I'm saying it's not a 1-year-old, it's not a 2-year-old that might have pyloric stenosis, it's an early aged child, because pyloric stenosis causes dehydration and weight loss. And so these patients tend to then be failure to thrive, which means that they are not gaining weight like we would expect them to. So child is usually lethargic, they're not gaining weight, they're younger, they're boys, and they're vomiting a lot. Those are kind of some really key signs for pyloric stenosis. The other sign is the olive sign. And what happens when this pyloric canal starts to thicken, it is about the size of an olive, and you can kind of feel that olive if you're palpating around on the stomach. You can feel that channel enlarging. So they call it the olive sign. As far as correcting pyloric stenosis, it's actually a really easy surgery. They go in, they cut open the pylorus and kind of shave down the muscle, basically, excise some of that muscle, and everything goes back to working just fine. And now there's a canal for food to make it out of the stomach. So it's actually a pretty easy surgery to correct, and then babies do just fine afterwards. So on ultrasound, finding the pylorus is probably the hardest part. Once you find the pylorus, and again, this is going to be numbers. You're going to have a patient that comes into the ER, they're going to be vomiting. ER doctor's like, well, I don't know, let's take a look for a pyloric stenosis. And the more you do of these, the more comfortable you will become with them. So looking for the pylorus, we are looking for a couple things. First, it's probably easiest to find the gallbladder because it kind of sits underneath the gallbladder. Here's baby's stomach. This is the antrum of the stomach. And then we see the pylorus coming off. And if you think back to how cervixes look, it kind of looks like a cervix in the abdomen of the baby. So we call it the cervix sign. And that's when we have the pylorus in long. When we are in the long view on the pylorus, our transducer is actually transverse on baby. And what you really want to find is that antrum of the stomach, and you want to find the center of the canal, because we want to see is anything moving through that canal. If we see any movement back up towards the stomach or out of the stomach into the duodenum, then it's not pyloric stenosis. They might be having a pyloric spasm, which is narrowing the canal, but it's not true pyloric stenosis. Pyloric stenosis says nothing is getting through there. When we turn transverse on this, then it is going to look like a target sign again, so it'll be kind of this little donut looking thing right in the same area. And we want to measure the pylorus. So we're going to measure the wall, and we're going to measure the length of the canal. And one of the ways that you can remember this is we're looking for pi. So the canal should be less than about 14 millimeters. Again, it depends on where you work. Some say up to 19 millimeters is normal, but we're going to go 14 millimeters. And the muscle, outer edge to inner to where the canal is, should be less than 3 millimeters in the normal patient. So if you get a measurement over 3 millimeters and over 14 millimeters in length, then we are going to suspect positive for pyloric stenosis. So here I have a video. Usually once we have the infant on the table, we're going to take some pre-pictures of the abdomen. We're going to try to find the pylorus. Sometimes you can just already see stuff moving through the pyloric canal, and you're going to want to grab a video of things moving through. If you see it, you're done. There's no, and all the measurements are normal, you're done. There's no reason to feed the baby or to take any more pictures because we've already proven that it's not pyloric stenosis. However, if you find the pylorus and it looks kind of thick or it measures kind of thick and you don't see anything moving through, then we really want to make sure that we're feeding the baby some sort of clear fluid just to double check that nothing is getting through. So this video here is going to show us an example of fluid moving through the pylorus. So here's the canal, and you can see, ever so slightly, you can see fluid moving through there. Let's watch it again here. Right there at the beginning, you can see fluid moving through. So that's really all you need to prove to your radiologist. What I have noticed when I've been scanning pyloric stenosis cases, the pylorus will open just a little bit and a little bit will go through, but then all of a sudden you'll get like this wide open pylorus, a bunch of it will gush through. The second you see that, you are good to go. That proves that the patient does not have pyloric stenosis. So really making sure that we're watching that pylorus, looking for any fluid moving through the channel. The other pitfall of using ultrasound to look at the pylorus is that an inexperienced tech might find the gastroesophageal junction and think that is the pylorus, and it is not. So this is the gastroesophageal junction. This sits a little bit higher. Remember, the esophagus comes in at the fundus of the stomach, so this is higher than where the pylorus typically sits, but it has a similar appearance to it. But look how superior you are. We're at the diaphragm right here. This is heart, this is liver. We're really high up on the patient. We should actually be below, a little bit closer to the gallbladder if we're finding the true pyloric canal. So as far as protocol goes for scanning a patient with suspected pyloric stenosis, we want to make sure that we are using, again, a linear probe. I usually start with my 12.5, my small parts probe, and then if I need to, if the baby's a little bit bigger, I might switch to the 9.3 probe. Typically I start with the patient on their back, or we're going to roll them up onto their right side. So that kind of gets the stomach to fall down a little bit more and puts the pylorus in more of a dependent position, so we hopefully will see fluid travel through it. Again, I had mentioned earlier that finding the gallbladder is probably one of the easier ways to get at least to the level of the pylorus, and then you kind of need to rock your probe back and forth, trying to elongate the canal and locating it. Remember, to elongate the canal, you typically are transverse on the body. Once you have the elongated canal in your image, then you should be able to take a measurement of the canal, the length of it, and then also measure the muscle in the AP. Remember that the muscle then should measure less than 3 millimeters for normal measurements. Over 3 millimeters is considered positive for pyloric stenosis. And then for your boards and your test, you can remember longer than 14 millimeters is considered positive for the canal, but some places do use up to 19. So we get that pi part of here for 3.14. That helps us to remember then 3 millimeters for the muscle and 14 millimeters for the canal. When you turn transverse on the pylorus, you should again be able to demonstrate a target sign or kind of like a round donut. Take again an AP measurement of the wall in this position as well, and then take any city clips that you need to, especially if it proves that fluid is moving through the canal. Lastly, if you get through all of this, figure out that it's most likely negative, then what a lot of places want you to do is look for malrotation of the gut. Malrotation of the gut can cause some vomiting in infants, and it kind of affects the same age range. So, midgut malrotation, let's cover that real quick. So, typically what will happen is you will get a an order for pyloric stenosis, and we'll figure out that it's negative. And because it's negative, then we just want to do a quick check. Does the gut look okay? Now, ultrasound is not super awesome at diagnosing midgut malrotation, but we can take a really quick picture and then look at how the SMA and the SMV are related to one another. So when the gut turns on itself or rotates, it's going to change the position of the SMV and the SMA. So we get kind of a whirlpool sign because everything's kind of twisted, and then we look to see where those vessels are. So in a normal relationship, the SMA sits kind of right above the aorta, and the SMV is typically to the right of it. In midgut rotation, the SMV is going to twist up and over and now be to the left of the SMA, or sometimes it only sits just anterior to it. So we want to take a quick transverse picture at the midline, looking to see how the SMA and SMV are related to one another. So after you've finished your pyloric stenosis evaluation, again, this is a really quick picture, just put color on. Here we have the aorta. Typically we would expect the SMA to be above it, but look, it's over here, and the SMV is on the other side of it. And this is an example of that whirlpool sign, seeing how the intestine is kind of twisted upon itself. Rotation of anything is also typically called volvus, so you might hear that term as well. When the midgut kind of turns on itself, it kind of pinches off the duodenum, and so we might see that there's some extra fluid within the duodenum as well. All right, another GI pathology that we can see with ultrasound on little kiddos is something called intussusception. And intussusception usually is going to happen either in the right lower quadrant or in the right upper quadrant. And the most common spot for it to show up is at that ileocolic area. So remember we talked about where the appendix is. We have the ileum and it joins up to the cecum, and the appendix then hangs off down here. That's also the most common place for intussusception to happen. And what intussusception is that the bowel kind of sucks in on itself. It telescopes in on itself. So we can see from this image here that the ileum is kind of gotten sucked into the colon. And so now there's part of the small bowel sitting within the large bowel. Now, intussusception can happen anywhere along the intestines. It can happen large bowel into large bowel, small bowel into small bowel, any of the quadrants, but most often it's going to be in that right lower quadrant. It's also more commonly seen in younger patients. So a 3-year-old with intussusception, totally normal. 2-year-old, totally normal. 5, 8, 11-year-old, not as common. Kind of like appendicitis though, they're not real sure why it happens, but what they think with intussusception is that there is some kind of like catch point. And they think catch points are usually some sort of lymph node within the abdomen. So that lymph node kind of hangs up the intestines a little bit, and because of that then it affects how they peristalse, and at some point then it just kind of gets caught up and then sucked into the rest of the bowel. So sometimes a patient who has been sick recently, maybe with like a gastroenteritis or just something that caused their lymph nodes kind of in general to enlarge, if they've had a recent illness, they're more likely to show up with that intussusception like a week or two later. Intussusceptions do not typically require surgery to correct. They can usually reduce them by filling the bowel with air, and then they'll kind of pop out. If they can't get it to go that way, then they can do surgery. And then small intestinal intussusceptions usually just fix themselves. It's not uncommon for it to happen and then kind of undo. Sonographically, you are not going to miss a large bowel intussusception. It's again one of those orders that you'll get from an ER doctor, be like, oh, the kid's in pain. Maybe, let's take a look. And you're going to sweep through and you're going to see so many negatives that you're going to start to think, am I missing these? but you're not. You are not missing them. You will see intussusception on ultrasound. It's very, very clear when a child has it. So sonographic appearance, we say that it has the donut sign and a pseudo kidney sign. So here's the right kidney. And let me tell you, the right kidney is going to jump out at you when you are scanning through these patients. The right kidney will jump out at you and be like, oh, is that it? And then you'll turn on it and be like, nope, that's the right kidney. The other thing that kind of throws me off is the psoas muscle down in the right lower quadrant. That also kind of looks like an intussusception. But again, it elongates, it has striations like muscles do, so we can rule that out. So here's the right kidney in this picture here. Right next to it is the intussusception. And you can see kind of why we call it the donut sign or the pseudo kidney sign. I'm going to show you a video in a second here too. It'll show that pseudo kidney sign even more when we elongate it. When we take measurement of it, we want to see multiple layers of bowel within the intestine. So you can kind of see on this one we have the intestine, and then we have more intestine inside of it. So we can see those distinct layers of the two parts of the bowel. Another common thing that we see with intussusception is what we call jelly stools or red currant stools. So basically it's red, kind of a gelatinous looking poops. And so if the patient has that, that's actually a really good sign that they probably have intussusception. So if we were to be watching this live, this part here, we would see kind of moving in and out of the area. Sometimes they can get very stuck and they don't move at all. If this was a small bowel intussusception, we'd most likely see this reduce or go away before the end of our exam. So here are a couple videos that I have of intussusception. These are both in the longitudinal view on the intussusception itself. So you can kind of see on the still, this first one here, the still image, we have the wall of the first part of the intestine, and then we have that second part coming in. And you can kind of see on these how these also kind of look like kidneys in the long view. So that's again why we get that pseudo kidney appearance. So this is actually in an animal, but same idea. We have the layers of the bowel, and then we have that second layer coming in here. And look how big these are. This is really how big it is. It takes up a big chunk of your screen usually. That's why I'm saying you're not going to miss this. So you can kind of see in transverse it turned into that target sign. And so I'm going to stop that one, and let's take a look at the other one here. Again, you can see the layers of the bowel. We have some free fluid in there because everything's kind of blocked up. And you can see how that second part, play that again. You can see how that second part is just telescoped into the first part of the bowel. Another less common GI tract finding that you might see, and honestly I haven't seen one of these before. I know of them, but I have not seen one before. It's called a Bezoar, and they're named for whatever they're made of. So usually it's just kind of this mass of foreign material that's kind of clumped together in the intestinal tract. And so there's a disease where people will pull out their hair and then eat it. And so that's a trichobezoar, where there's a bunch of hair in the intestines. You can have a phytobezoar, so if a child can't digest plant material very well or doesn't chew it very well, you can get a big clump of that in there. You can also have lactobezoars, so if a baby can't process their milk very well, then they might get a big ball of kind of like crusty milk in their abdomen. So they just kind of look like shadowing irregular things kind of within the intestines. You're not going to be able to look at it and be like, oh, that's a trichobezoar. You might just say that, you know, there's kind of this abnormal structure within the intestines. They're going to be better viewed by x-ray or even endoscopy. So again, if you're scanning a patient for abdomen pain and you just kind of see something weird in the intestines, don't be afraid to take pictures of it. It might help to get the patient to the right diagnosis. Some other even less common findings that you might see in the abdomen is a duplication cyst. Probably learned about this in OB, but it's basically just kind of like a doubling of the stomach area. So there's a cyst where we would expect kind of a cyst where we would expect the stomach to be, and then there's the actual stomach. So that's the duplication cyst. So it's just kind of a cyst area in the middle of the abdomen that shouldn't really be there. Mesenteric Lymphadenitis. This is the one that I was saying that really mimics a lot of the appendicitis symptoms. So you might have a patient that just doesn't feel very good. They have a lot of abdominal pain. You get in there, you start seeing enlarged lymph nodes, and then you start to think, well, I know enlarged lymph nodes go with appendicitis, but you can't find appendicitis. And so it's not uncommon for those lymph nodes to get enlarged. Causes the patient pain because they've got other stuff going on, and that's where we get the mesenteric lymphadenitis from. So they're going to have increased white blood cells with this. They're going to have a fever with this. Like I said, it really overlaps a lot of the symptoms, but we don't find that positive appendicitis along with it. A patient could have this too as a precursor to getting intussusception. And then necrotizing enterocolitis, or NEC is how it's usually abbreviated down to. This is more seen in premature infants or infants who have had surgery shortly after birth. Basically what happens is that the blood vessels into the intestines just aren't developed enough. And so there's not enough blood getting down to the intestines, and so because of that, the intestines start to die or start to necrotize. And when that happens, then we are worried about perforations of the bowel, where the bowel wall gets weak and ruptures. And if that happens, we're going to start to see more air in the abdomen. We're going to see loops of bowel that are very thick and kind of gross looking, and then we might even see some air within the portal venous system. All right, so we're going to switch gears a little bit into the pediatric side of kidneys and the urinary tract. So I just want to preface this portion with, again, this is not by any means an encompassing review of pediatric stuff. A lot of the pediatric things that we'll see mimic the same things that we'll see in adults. So we're always going to be, they're more likely to have hydronephrosis. We're looking for any sort of reflux up the ureters. We're looking for uretocils. We're looking for, again, hydronephrosis, obstructions either at the bladder or obstructions at the pelvis of the kidney. Those things are a little bit more common in children, but they look the same as they do on adults. So any sort of fluid within the kidney is not uncommon in children to see, but of course we need to document it and take pictures and everything, because that is a common finding. What we're going to focus on for the pediatric part of the kidneys are the malignant tumors that arise from the kidneys, because again, those are easy board questions, and then some other common things that you'll see along with the kidneys. So first, we're just going to start with talking about that neonatal kidneys actually look really different than adult kidneys. And when you first look at neonatal kidneys, you might think, whoa, there's tons of cysts in here. Well, they're not. They actually have super prominent pyramids. So this is a neonatal kidney. We can see those fetal ovulations very clearly, and we can see the pyramids. And the pyramids are super dark. They almost look like cysts. And then we have kind of a lower echogenic parenchyma and then kind of a lower echogenic sinus. So they just take on a little bit of a different appearance compared to what we usually see for the adult kidney. I have that adult kidney on the bottom here just as an example. This chart here helps you just to kind of visualize or sort out what the differences are between neonatal kidneys versus adult kidneys. I think the biggest one that I want to point out is, again, that the pyramids are super prominent and hypoechoic almost to anechoic, and that in children we expect the average size of kidneys to be within 1 centimeter. We teach you for adult kidneys you can have up to 2 centimeter difference in size. It's only 1 centimeter for kidneys, so highlight that. 1 centimeter for the kidneys in children is a okay difference. Anything over 1 centimeter, we're going to start to worry about some sort of disease or pathology. I also want to point out that the adrenal gland is actually visible during the neonatal period. And so if you see kind of this weird wormy structure sitting on top of your kidneys, that is the adrenal gland. And typically this area kind of fills in with fat, and the adrenal gland becomes a little bit more echogenic in adults. So we actually can see the adrenal glands on adults, but not anything like this. And it's not something that we typically evaluate adult adrenal glands for unless there's a mass in there. All right, so nephroblastoma is a pediatric cancer that arises from the kidneys. And this is also known as a Wilms tumor. Highlight star, underline, circle, exclamation point. Wilms tumor is another name for nephroblastoma. Know that. Put that in your memory right now. The other thing to put in your memory, this is the most common malignancy of the abdomen in children. So nephroblastoma is number 1. We're going to learn in a minute here that neuroblastomas are number 2. Hepatoblastomas are number 3. So back to the nephroblastoma, or the Wilms tumor, usually arises from the kidney. It's going to be a large mass, typically unilateral, and it'll occur before the age of 5. Typically between the ages of 2 and 5, to be more specific. When these patients come to clinic, they are going to have a palpable abdominal mass. They're probably going to have signs of hypertension, showing a claw sign on CT. And again, this is also associated with Beckwith-Wiedemann syndrome. So hepatoblastomas and nephroblastomas are both associated with Beckwith-Wiedemann syndrome. On ultrasound then, we're going to see typically a solitary mass that's a little bit more on the echogenic side and heterogeneous. And again, it's going to be arising from the kidney. So we can see here we have renal parenchyma surrounding a solid tumor. Renal parenchyma, solid tumor, renal parenchyma, solid tumor. This one is starting to have some more cystic changes to it. As they get larger, they tend to become a little bit more heterogeneous. We might also see a pseudocapsule around it, so basically just kind of a hypoechoic rim that surrounds the tumor. As they get larger, they start to invade the different areas, different blood vessels around the kidney. So it's not uncommon to see it invade into the IVC, causing Budd-Chiari syndrome. And if we put color on these, we're definitely going to see a lot of blood flow within the tumor. Now, neuroblastomas are malignancies that arise from immature nerve cells. And neuroblastomas usually pop up at the adrenal glands. So you can think of neuroblastoma and adrenal glands going together. The other spot that they come up is on the spine, which is probably what you would think of more, especially with the neuro prefix. But neuroblastomas are most commonly seen at the adrenal glands. These are going to be typically seen in children from the ages of 1 to 5. And it's the most common malignancy in children less than 1 year old, but it's the second most common childhood abdominal tumor. So again, nephroblastoma is number 1 abdominal tumor in children. Neuroblastoma is number 2. Hepatoblastoma is number 3. We're going to put a little asterisk next to neuroblastoma. If they are young, on the younger side, like that 1 and younger, it's going to more likely be a neuroblastoma. Clinical appearance for the neuroblastoma then is again an abdominal mass that's palpable, hypertension, patient might have diarrhea, and then if it is metastasized, they might complain of bone pain. So the neuroblastoma on ultrasound is typically very well defined, and it is going to sit in between the liver and the kidney on the right side, or the spleen and the kidney on the left side. They typically are a little bit more echogenic with increased vascularity. As the tumor grows, it's going to start to displace the kidney a little bit more inferiorly, or it could even push it a little bit more lateral. With neuroblastomas, it's not uncommon to see calcifications, but sometimes those calcifications are a little bit clearer on X-ray. So here we have a neuroblastoma. This one actually looks like it is identified in the prenatal ultrasound, because we can see a placenta here, it looks like. So we have a very echogenic mass off the left kidney that was proven to be a neuroblastoma. Here is an example then of a postnatal example of the neuroblastoma. We have liver here, a very echogenic mass with the right kidney kind of being pushed off. Typically the liver and the right kidney share an interface, right? They're usually right next to each other, but now we have this large echogenic mass pushing this out of the way. So we notice that all of our masses are usually solitary. They're usually going to be unilateral. They're large masses when they are seen. They're very fast growing masses. Some other adrenal abnormalities, I kind of just included this in here just as a more of an FYI. Again, if you have a neonate floor at your hospital and they just want to take a quick look at the kidneys, you might see kind of this irregular area superior to the kidney. So here is our normal kidney. Again, we can see the fetal lobulations, we can see those pyramids, and this is the area that the adrenal gland sits. And it's not uncommon for neonates to have adrenal hemorrhage. Usually through the trauma of birth, it just is kind of like a big bruise here on the adrenal gland, and so we might see some heterogeneity in the area between either the liver and the kidney or the spleen and the kidney, and so that's usually deemed an adrenal hemorrhage. The last abnormality that we'll talk about, that I want you to know about, is called a urachal abnormality. And the urachus is this kind of ligament area that comes from the top of the urinary bladder and attaches to the umbilicus, or to the belly button. And what you'll see is patients come in with their kiddos complaining that their belly button has a rash on it, that their belly button's red, that their belly button seems to be leaking liquid. And if they have a patent urachus, that means that urine is actually leaking up and out of their bladder and out of their belly button. So not an uncommon thing that we look for. So that's why I kind of threw it in this one. But usually the urachus closes and it's just kind of this tract that has no connection to anything. It just kind of holds the bladder in place. Sometimes though, it is completely open. So again, the urine can come right out the urachus and out the belly button. Usually just kind of dribbles out. It doesn't spray out or anything like that. We can then see some variants on this where we can see just a random opening, kind of like a cyst along the track of the urachus. We can see partial open, either up towards the belly button or down towards the bladder. So there's a few different variants. The biggest thing is to find the bladder, make sure that the bladder has liquid in it, and then also center that on the umbilicus and look for some sort of tract connecting between the two. If there's fluid in there, then we expect it to be a patent urachus, as this one is here. Or we have an example here, we have a cyst along the urachus. This again is not an uncommon thing that I see quite often. What I see is this little diverticulum right at the top of the bladder. You'll see kind of this thickening where we would expect the urachus to be, and you might see like just this little tiny cyst in that area. And so that's usually a very normal finding. It's just a little urachal cyst. Just to wrap up this lecture, I just want to cover some just general tips and what types of transducers that we want to use. Now, when we do most of our abdominal work on adults, we're using our low frequency curved linear probes, our 3 to 5 linear megahertz probes. When we are scanning infants, start with the highest frequency that you can. They're itty bitty. You can use higher frequencies. So I like to scan kidneys on infants either using like a 12.5 probe coming from their back, or I use a micro convex probe in like the 8 megahertz range. Works out great for the whole abdomen and kidneys. Older children, I definitely start with like a 9 megahertz curved linear. Those again give us really good definition of the abdomen structures. And then adolescents or overweight children, I'm definitely just going to go back to my 3 to 5 curved linear array. When we're doing anything GI tract, you're going to want to start with your 12-5. If you can't see well enough, then you're going to go to your 9-3. If you still can't see well enough, then you're going to go down to a curved linear. But ideally, GI tract stuff should be imaged with some sort of linear probe, again, starting with your 12-5 and then moving to your 9-3. Some other general tips for scanning. When you're scanning babies, happy babies are easy babies to scan. So make sure that they've been fed, make sure that they have a pacifier and that they have a clean diaper. Amazing what it does for the happiness of everybody in the room. Mom's not freaking out that she has to feed baby. Baby's not freaking out because baby's happy. And you're not freaking out because you get all your pictures and can show a good case to the radiologist. So usually if baby comes in and is already crying or screaming, I stop and say, has baby eaten? And they're like, no. I'm like, okay, I'm going to give you 20 minutes. Go ahead and breastfeed. If they can, if they're not having an abdomen ultrasound. I should preface that. Or if they are bottle fed, sometimes I just say, let's go ahead and prop baby up. You can feed. I'll scan while you're feeding. It works wonders. The other thing that you might hear somebody say is, can we give them sweeties? And sweeties is just a sugar water. They dip the pacifier into it or dip the pinky into it and let the baby suck on it. Calms them right down. It's a wonderful, wonderful thing. So if you do any pediatrics, you most likely have some sort of sweeties in the room. As far as explaining to mom, dad, and the child, make sure you are explaining everything to the parents and to the child if they can understand. Use correct terminology for both. Let the child touch the gel. Use fun words. Be positive with it. Like, I never say that something, I don't say it's not going to hurt. I say this might tickle, or this is going to feel funny, or do you want to touch my silly gel? Using kind of those fun terms makes it much less scary. Let them watch. Let them watch the screen. Let them touch. If they bring a stuffed animal in, I scan on Teddy first. Show them what I'm going to do. Or I scan mom's arm. Show them what I'm going to do. It usually helps them to see something, see that it doesn't hurt, see that it's all okay, and then they'll let you do it. If they can't, then they can't. Then there's other modalities of testing. There's sedation that can be done. If we have to get a test done, we can sedate a child to do it. We don't want to if we don't have to, but we can. My other big comment on this one is make sure mom and dad are comfortable with everything that's going on. I was scanning a child's hips, and they usually come in at about 6 weeks old. So mom's super hormonal, and they always cry during hip ultrasounds. Nothing's going on, but they're half naked, they're cold, they don't know what you're doing, and you're trying to move their leg around in ways that they don't want it moved around. And so I was scanning this kiddo. Mom starts sobbing because her kid is crying, and I didn't want to be in the middle of it, be like, I'm not hurting her, like, and it's just hard to communicate that sometimes. And so I've learned since that I'm going to be straightforward with parents. This is what I'm going to do. This won't hurt. They're going to cry. And ever since I started including what to expect for parents out of the exam, it has gotten so much better. So again, communication, you'll get your spiel down, listen to the senior techs, what they say to the parents, and then try to mimic that. And then lastly, NPO and bladder prep. If we have a patient that's coming in for an abdominal ultrasound, most of the time children are never just going to get a right upper quadrant or just the gallbladder exam. They're usually going to get a full exam where we look at the liver, gallbladder, kidneys, we look at everything. And so those patients do need to be NPO. We don't typically keep them NPO for as long as we would for adults, mostly because babies need to eat quite a bit more often. So we usually try to do, where I worked we did 3 hours, but like a 3 to 4 hour window is plenty for an infant to 2-year-old. You can increase that time then as they get older and kind of understand. Pelvic ultrasounds, if you are needing to look at the uterus or the ovaries, then we want to make sure that we're getting juice, water, or milk into the baby about 30 minutes before, and then we can scan. And then older children should be able to hold their bladder and drink more liquid at the time. It is not uncommon for you to get, especially on females, to get an order for appendicitis and to rule out ovarian torsion. So it's not uncommon that you have to fill that bladder. A full bladder, though, can inhibit seeing the appendix. So what I usually like to do is have them come over for their appendix scan, and then I'll have them drink their water in between. And hopefully by the time that I have scanned the appendix, then their bladder is full and we can switch over to the ovary side of things. Otherwise, if their bladder is already full, then I'll do ovaries first, look for the appendix. If I can't see it, then I have them empty their bladder and try to look for the appendix again. So kids are amazing. If you have the opportunity to work at a pediatric hospital, I 100% recommend it. You will learn so much more. You'll learn a lot of really great skills. You learn how to handle little people, little children, how to deal with the different developmental ages, and there's just a lot of satisfaction that goes into the job. And then also dealing with the parents, you just learn new techniques, new communication styles that can bring you a long way. You know, as we are talking to other adults, we kind of expect them to have some sense of what we're talking about, but medical literacy is actually really low in America. So a lot of people don't know where their uterus is. They don't know what their gallbladder does. And so what I have found is working in the children's hospital and having that mindset that I have to explain things to everybody like they're little kids has really helped me a lot with my communication with adults as well. So just something to keep in mind. Hopefully this was a good introduction to the pediatric abdomen, and I hope you get a chance to utilize some of this in clinics or in your first few years out at your new job.